Welcome, everyone. It's good to see you and be with you. Uh, we're grateful for your time and want to treat it respectfully. So we're going to talk, as I mentioned, about pancreatic lesions today. These are all lesions that can appear somewhat similar on radiographic or ultrasound exam in that they can all be cystic or have a cystic component. Now, many of them are more commonly solid, but some of them are predominantly cystic. But we'll start with the most common lesion and one that is almost uniformly cystic, but may have a solid component. And in our environment, we use this acronym, IPMN, very liberally, but it stands for intraductal papillary mucinous neoplasms. And we use the term neoplasms because these can be quite benign, or they can be of kind of in situ malignancy, and they can have an invasive adenocarcinoma component. So they run a very broad spectrum of biologic potential. They come in sort of two varieties, what is termed the side branch or branch duct IPMN, and then the main duct IPMN. Histologically, the cells look very, very similar, probably the same type of cells that we see in what is also described as pancreatic intraepithelial neoplasia. And as a consequence, these do have this risk of developing malignancy. That is usually a ductal type of adenocarcinoma. But having said that, these cysts are also very commonly discovered as an incidental finding and may be followed for a period of time radiologically without requiring surgery. Usually the things that trigger the need for surgery are symptoms, pain, enlargement, or if cytology or biopsy is obtained, any degree of cytologic atypia usually will trigger the need for surgery in these cases. Now, I have several histologic examples. Most of them are in the pancreas, but I also have some from the liver. Because this is also a lesion that can occur along the biliary ducts in the liver and even in the gallbladder, as you may recall from our session last month. So here's the first case, and it actually is one from the liver, as you see a little bit of liver tissue around the margins here. The multiple cystic structures here is common. They can be multiple or they can be single macrocystic type of lesions. But one of the common features is that there's a degree of papillarity to the epithelium, which we see right here, up here as well. In this one, I don't believe there's much in the way of cytologic atypia. And typically, these cells are just slightly enlarged. So here's a very low-grade atypia here, just slightly enlarged biliary type epithelial cells, maybe a normal biliary structure over here. And then here would be a more fully developed early dysplasia type of thing with enlarged cells, a little bit of nuclear enlargement, and some crowding. And as you can see in the liver, this is admixed with other degrees of metaplasia and biliary ductal proliferation as well that gives it this appearance. We'll look at another case just to further expand the spectrum of things that we can expect. And here you see this very prominent papillary component to this neoplasm. Now, I mentioned that these are mucinous neoplasms. There are also rare examples of oncocytic type of lesions with this kind of architecture. And those are called intraductal papillary oncocytic neoplasm. But those are extraordinarily uncommon in my experience. Here we see a little higher degree of cytologic atypia. You see some of the cells have nuclei above the basal area, and there's more variability in some of these cells, and maybe a little bit less mucin production. Additionally, we start to see some exfoliated or apoptotic cells within the mucin, which is often an indication of a more aggressive or potentially in situ malignancy or worse that is beginning to evolve. Here in the pancreas, we see there's a very dense fibrous stroma associated with this. And so looking at the stroma is important because we want to be sure to distinguish this lesion from the mucinocystic neoplasm that we'll talk about later. Whenever you see this kind of proliferation present within a lesion that's been resected, you want to look very carefully to make sure that you don't have occult invasion. So looking at an area like this to make sure that this is not truly invasive neoplasia. It's not right adjacent to a large vessel, so it still is there. But then you also want to look for evidence of invasive neoplasia. And so little nests like this could be the harbinger of invasive component. And so looking carefully, not just at the big picture, but at some of the smaller areas like this, to ask the question, could this be an invasive component? Now, that can sometimes be a difficult question because as these lesions expand, they compress the residual pancreatic epithelium, and the acini degenerate and invert, I guess, or disappear essentially, leaving just the small ductal elements, which can look very much like an invasive tumor at times, unless, and usually you like to see a little bit of lobular architecture, but this inflammatory process also helps you. But looking to see if you have perineural invasion, you'd want to ask, is this perineural invasion here? Or do we have other kinds of tumor that is present immediately adjacent to large vessels in an area such as this, where there shouldn't be normal acinar tissue? Those are the clues that we use in a setting like this to determine whether we have invasive neoplasia. Now, of course, you can also get a degree of pancreatitis associated with this. And here we see that change as well with areas of inflammation. The islets, of course, when you have duct obstruction or damage, will not be prone to regress. And so here you'll have a few areas with residual islet cells present in these lesions. Now let's look at another example. I think I've got another case example here. So here's one where we have much more abundant mucin, as you see here. And it's kind of a more viscid mucin. And that's one of the features that we see in this tumor, is especially with the main duct IPMN, is that these lesions will oftentimes have mucin that's very copious, that's extruding from the ampulla. And so at endoscopy, they may see that happening. And it's because this is a very highly productive mucin. Now here we see there's a higher grade dysplasia. you've got some residual mucin cells here, but you also have, nearly cribriform solid type of tumor, as well as considerable dissection of the mucin into the soft tissues, or forming this sort of pseudomyxoma type of pattern. These can be very challenging to identify margins and so forth. In the excision of main duct IPMN in our institution, they will often ask us to freeze the distal margin of the main pancreatic duct to see not if we have IPMN present, because usually this will occupy the entire main duct, but to see if we have high-grade dysplasia or invasive carcinoma at that site. And so if this were our margin section, we would say, well, we see certainly high-grade dysplasia, but looking over here, we also see this mucin dissecting into a lymph node, as you can see here. Now, we'd have to look at this very carefully to see if we have identifiable neoplastic cells, which I think we do have some here, along with this mucin. So it's a very mucin-rich carcinoma that's developed in this case, and it's directly invading a lymph node. That still qualifies as a lymph node spread, so you'd stage it as an N1 lesion, even though it's probably just direct extension into the lymph node. But in terms of staging, the direct extension, metastatic, subcapsular extension, those are all treated the same way in our staging criteria. Now, another question is kind of maybe even a little bit more academic. If you just had acellular mucin, and let's say an area like this in your lymph node, and you could not identify tumor cells, if these were non-epithelial cells, as these appear to be in this node, would that be classified as a positive lymph node? I think the answer to that is no, that you do have to see the epithelial component to assign that lymph node an end stage indicator. That's most commonly seen when something's been given neoadjuvant treatment and some of the tumor has regressed in the esophagus or stomach. We often see that situation in the rectum, less frequently in the pancreas. But it's certainly true that with neoadjuvant therapy, the amount of viable cancer will diminish, but that will not impact the mucinous component of these tumors. All right, here's another example, and here you see it's a main duct, but it's extending out into the small branch ducts. And I show this case because this is a somewhat subtle case where if we look here in some of these surrounding tissues, like right here, we can see that, in fact, here we have very clear-cut carcinoma here adjacent to lymphatics and large vessels. This is not an area where we should find residual lobular breast acini. And so considering this as potentially an invasive component would be the most viable solution or interpretation in this case. So just that little caveat to always be on the lookout in these areas where they shouldn't be, to make sure that you don't have an invasive component in one of these tumors. This one again is one where we see pretty high-grade dysplasia here in this lesion, such that you would, at the very least, call it carcinoma in situ or high-grade dysplasia. Feel free to type any questions in the chat as we go along if I don't happen to see your hand raised. So the next lesion we'll talk about is one that is less frequently resected, and therefore pathologists are maybe less familiar with it. But that's a good thing, because this is a lesion that doesn't need to be resected unless the patient is symptomatic from the lesion and it's become large enough that it's producing either obstruction or intermittent obstruction, or interfering with drainage in some way, or otherwise causing a problem. And the reason it's not resected is that oftentimes the radiologist can identify this. It tends to have very distinct margins, have a hypointense appearance, and has oftentimes a sort of central scar-like area that gives it away under the appropriate CT scanning mechanisms. Now, we call it a serous cystadenoma, but it is entirely unrelated to the ovarian serous tumors. And so it's an unfortunate common name, but not a common histology in the sense of histogenesis. So I did manage to find a couple of examples of this. Here's one that's sort of a mixture of macrocystic and microcystic lesions. You can see here a nice sharp border. As you might imagine, the epithelium that lines these cystic spaces is kind of what we would expect for a serous tumor. The cells tend to be very low grade and have widely spaced nuclei. As you can see here, there's a lot of space between nuclei. And the cell tends to be very cuboidal or even rhomboidal because their nuclei are so far away from one another. And that this very collagenous matrix is common. And oftentimes that's what is the giveaway from the radiographic standpoint, is this more central scarred area. It's uncommon for these lesions to have an associated endocrine element, but on occasion that has occurred. And I think I have an example of that a little bit later on. But you can see there is still some, acinar tissue adjacent to this. And so you may have variable combinations of viable exocrine function as well as endocrine function. Here's, I think, a few islets here, as you can see here. A little bit of residual endocrine function. Here's another example. This one, a much more macrocystic example. It has a single, very large space, a little bit of a scar, and then a few other sort of mixed macrocystic spaces. And so in these, sometimes the epithelium can be a little bit hard to find because it's so bland appearing, but it almost looks like a mesothelial type surface. Now, oftentimes the endoscopists will sample fluid from these lesions, and they may at times send it for things like CEA or amylase and those sorts of questions. And these tend to have obviously very low CEA levels. minimal amounts of amylase. And so they'll have a pretty benign appearing chemical profile as well. So moving on here, here's the combined case that I mentioned to you. We have the serous component over here, and then we see here adjacent to it a different appearance. I don't think this is a very common circumstance, but when the radiologist sees a more conventional serous lesion, such as this, a lot of scarring, macrocystic spaces, very low cuboidal epithelium, and they see a solid component, well, that's a good indication that there may be something else going on. And so, in fact, here we see this nested tumor with a very clear cytoplasm type of appearance. The tumor is in sort of little balls and nests. And so it could be a paraganglioma with a Zellballen type of appearance. You might consider that the way these are nested, and might have a little S100 positive sustentacular cells around them. But this did stain nicely with the conventional neuroendocrine markers of chromogranin and so forth. So probably the neuroendocrine component is the more serious element here, and would warrant the greater concern for follow-up or recurrence, or potentially other biologic behavior. Now, usually neuroendocrine cells have a little bit more eosinophilic cytoplasm than this, but we do see clear cell neuroendocrine lesions in the biliary tract, and I think I may even have one more example of that later on. So here's another serous lesion, just for additional examples of the various morphologies that you may see. And I think I've given you all the clues we need to discuss this. So if you want to come back and study the slides, of course, they'll post the link for these slides with the video when we put that up. But hoping that these numerous examples help you to see some of the spectrum of disease and patterns and morphologies that can be seen with these lesions. So another mucinous tumor, of course, is the mucinous cystic neoplasm. And again, we use the term neoplasm because the potential for benign, borderline, and more aggressive invasive neoplastic processes is present. Usually these are on the lower grade spectrum of things, but they do have a significant risk of malignancy, and therefore, as they're identified, they may need to be removed. The epithelium is very similar to what we saw in the IPMN. It doesn't tend to have the papillarity and so forth that we see there. And additionally, it has a very characteristic ovarian type stroma. So this is a lesion that if you don't know where you are, you might think you're in the ovary. Additionally, it has these serpiginous scars that look a little bit like a corpora albicantia. Females are much more frequently afflicted with this lesion. It's one of the few pancreatic tumors that is more frequent in females. There's one other we'll talk about. But males can also get this same lesion and have the same features in the stroma. So again, this is a lesion that can occur at any point in the pancreaticobiliary tree. So intrahepatic lesions are possible, and I think we talked about some of those last month. Here we see this mucinous epithelium and this distinctive stroma, quite cellular, and looking a lot like ovarian type tissue. We do have a few goblet cells in the mucinous component. So it may have a mixture of both enteric types and so forth. Now, the liver here is a kind of an end stage feature with just a few areas of viable hepatocytes left, and most of this tissue is just proliferated bile ducts in this dense fibrous stroma. So I don't think this is truly neoplastic. I think this is just kind of the end result of massive hepatic failure. This was a transplant patient, and they usually don't transplant widespread biliary neoplasia. Plus, you see there's sort of an organized architecture to it and so forth. Here's another example of this lesion. And again, the stroma stands out quite nicely on this. This has abundant amounts of the stroma. And as you see, the mucinous epithelium lining this is quite bland, not thrown up into any sort of worrisome appearance. Just a small amount of cytoplasm in this, not quite as basal as in the IPMN. But again, you do want to look to see if there is evidence of dysplasia, because that can be focal. And I'm trying to remember if we did have some focal dysplasia in this case or not. I don't think I see anything that looks dysplastic here right off the scan. So I mentioned that the stroma has a distinctive immunoprofile, and here we see what we would expect with a hormone marker, either ER or PR. I believe this is PR. Here we get a nice positive reactivity in the stroma, not in the epithelium, which is, of course, what you'd also see with mucinous neoplasms in the ovary that are not usually hormonally positive. Additionally, we did an inhibin stain here as well. And as you can see, we get a nice positivity in the stroma in many of the stromal cells. So if you're in doubt, you can do one of those markers to see if you have evidence that it's ovarian type stroma. Well, let's talk a little bit about neuroendocrine tumors. This is an interesting phenomenon. As we look at the incidence of neuroendocrine tumors, it's not just the Steve Jobs effect. You know, it's not just the rich and famous who are getting these lesions, but they're increasing in frequency and incidence quite broadly around the world. Of course, most of these are well differentiated and non-functional, but even though they're well differentiated low-grade tumors, they can have variable biological behavior, as you know. They can metastasize, they can spread, they can recur. And so identifying them and being able to diagnose them is, of course, important. Now, because we tend to see more islets in the tail of the pancreas, these lesions are more frequently encountered in the tail of the pancreas than in the body, but both sites are really quite possible as well. And these lesions can become cystic. So although they're usually solid and nicely rounded and so forth, if they are a little bit degenerate, they can become cystic. So I apologize, this is one that's up in the ampulla, and I apologize for the scan lines. But in contrast to the well-differentiated varieties that we most commonly see as we come into high power here, you'll see this has a less organoid pattern architecture. And at higher magnification, I think you'll appreciate very readily that this is a high-grade neoplasm. We have nice nuclear molding and a little bit of packeting here. but there's a very high mitotic rate, a very high NC ratio. So this is a high-grade neuroendocrine carcinoma, almost essentially a small cell carcinoma of neuroendocrine type that's occurring in the pancreas. Now, as you know, we typically divide the grading of the well-differentiated versions into 3 grades, 1, 2, and 3, based on mitotic activity and on Ki67 proliferation rates. And I'd emphasize the value and importance of doing the counting on those Ki67 rates. If you don't have an automated counting mechanism, it's best to just take a photograph and count every nucleus and figure out how many positive Ki67 cells you have. So this is a more diffuse pattern, almost a little bit of amyloid in here, which could suggest that this is an insulinoma. And so seeing the presence of amyloid-like hyaline fibrous tissue here is a marker that's more frequently encountered in insulin-secreting tumors, but it's not an absolute criterion. It's just a looser association. But here you see very eosinophilic cells, fairly bland nuclei, and you'd have to hunt for a little while in this to find mitotic figures. Now, if you're on the lazy side, like I am sometimes, is I will order a phosphohistone 3 stain, which is a very good surrogate marker for mitoses. And so I will use that as a marker of mitoses and count that in a representative area to provide a mitotic count as well as the Ki67 rate. But if you don't have access to that stain, you have to just rely on microscopic H&E morphology to identify mitoses. And here's one more neuroendocrine tumor. Again, notice a lot of hyaline tissue here, but very sharply circumscribed, a little bit more, not really lace-like and so forth, but differentiated enough that you'd look at this and say, oh, this is a neuroendocrine tumor. Now, again, you might, with this small packeting, you might raise the question of, could this be a paraganglioma? And in that case, you would, I think, want to do an additional S100 stain to see if you have the sustentacular component as well in that. Note that in some neuroendocrine tumors, there can be a degree of nuclear pleomorphism. That does not correspond to malignancy or more aggressive behavior, unless you have the associated high mitotic rate that goes with that, such as we saw in that first small cell carcinoma. Now, the thresholds that we use for Ki67 are less than 5% is a grade 1 tumor, 5% to 15 to 20% is a grade 2 tumor, and then anything over 20%, definitely a grade 3 tumor. So those are the thresholds that are in the literature. Now, here's an example where it did become a little bit cystic, a little bit more nested and so forth in this case. And you see the associated wall here. I think this is actually up in the bile duct. And you can see, again, more dark appearing cells, a little bit less cytoplasm in these cells than in some of the other examples that we've looked at here. But the sheet-like growth, nested growth, trabecular growth, occasional cystic change, those are the morphologies we usually associate with neuroendocrine tumors. Well, another tumor that's frequently encountered in the tail of the pancreas is the lymphoepithelial cyst. And this is an interesting lesion because we don't know exactly embryologically how these where these develop. Certainly, we occasionally see similar cysts in the spleen, as well as in the tail of the pancreas. So whether these that occur in the pancreas are the result of ectopic splenic tissue that has regressed, or whether it's truly a true cyst, an inclusion-derived cyst in the pancreas, we don't really know. I tend to myself to like the spleen version because I think that ties together the histogenesis. But even in the spleen, we're not quite sure why you get these inclusions, unless it's an embryologic phenomenon that then over time develops and produces a dermoid cyst, essentially, with the accompanying lymphoid component. In the pancreas, though, sometimes this can look like a pseudocyst, and so it can get aspirated cytologically and so forth. Again, it's not something that has to be removed unless it's growing or causing symptoms and so forth. It tends to have a squamous epithelial lining and variable amounts of surrounding lymphoid tissue. And of importance here, we usually do not see germinal centers in this lesion. So it's not frequently resected. I think in our institution, we see maybe one a year or something of that sort. But here you can see this nice sort of keratinized content, very lamellated keratin, acellular, no nuclei here in this. And then when we come to the lining, we'll see that that's the result of a squamous epithelial surface here that's stratified. And although it doesn't look like it's keratinizing per se, it can in some areas, and it may or may not have a granular layer. But stratified squamous epithelium and the surrounding lymphoid tissue gives you the diagnosis of lymphoepithelial cyst. Now, notice here you also see these lipogranulomata here, little clusters of lipidized histiocytes within the parenchyma. This is usually the indicator of some sort of, alteration in the fat metabolism in the areas surrounding these lesions. Usually we see this in the porta hepatis or around the gallbladder and so forth, cholesterol related. But these lesions can also produce a lot of cholesterol and result in cholesterol clefts that would then potentially drain into lymph nodes. So here's an area where we can see that the lining has a granular layer here. It almost looks a little bit like coarse keratohyalin granules that you see with a wart or a human papillomavirus related type of lesion. But it's anyway producing keratin and exfoliating these cells. So I see there's a question. Very good question, Dr. Lin. We're going to get to a differentiation of solid pseudopapillary tumor from neuroendocrine tumor when we do the solid pseudopapillary tumor here in just a few minutes. So hold on to that question, because that's the next topic. Here we are. Just perfect timing. So this is a tumor that is, again, a younger patient. And that's a very important giveaway. I did a separate video on this. That's why I've got this nice rich slide here. But these are usually found in young women. Very high proportion of women, much less in males. And it's usually in the body or tail, but occasionally can occur in extrapancreatic sites, including the ovary, which is a very interesting phenomenon. It has a low malignant potential. It usually is local growth rather than any metastatic potential, but it may recur if it's not completely excised. And in its sort of nascent or early stages, it has these very papillary type fronds that have a hyaline stalk. And the cells that emanate from that stalk are relatively poorly cohesive. They tend to have grooved nuclei. And it's associated with a beta-catenin expression, both in the nucleus and the cytoplasm, because there's a TTNNB1 mutation, which is responsible for that expression. So this is the stain that we consider most useful in this lesion to distinguish it from neuroendocrine tumors, because neuroendocrine tumors will not be positive with beta-catenin. And so we will do this stain if there's any doubt in terms of the etiology. Because as you know, the synaptophysin and so forth, CD56, these can be positive in this tumor as well as in obviously neuroendocrine tumors. And additionally, the alpha-1 antitrypsin or chymotrypsin stains can also be positive, which puts it in a little bit of overlap with the acinic cell lesions as well. It does tend to be negative with chromogranin, but in terms of ruling out neuroendocrine tumors, that's not a very specific negativity. However, if you see a negative chromogranin and a positive beta-catenin, that certainly would be good evidence for solid pseudopapillary tumor. So I have several examples of this lesion. Here's I think this is my nice young patient. But here's a tumor with very little degenerative change. It's all pretty solid. There's no areas of necrosis or anything like that. And it's nicely contained. And I think we'll see here this where it gets the pseudopapillary name from. So because when it's growing in its native state, it tends to be solid. And it's just this poorly cohesive nature of things that tends to give it this papillary architecture. But in fact, these are, fibrovascular cores, and there is a cell, radiating out from these central little hyaline cores that extend. But they're oftentimes contiguous with the adjacent ones if you have good fixation and good circulation and a fairly young patient. But you can get areas of degenerative change with necrosis, and then these areas tend to become more pseudopapillary, or they tend to become more papillary because they will become more discohesive one to another. So we'll look at another example here. Again, a very solid appearing tumor, and very blue as well. So looking at this tumor, we might well think about a neuroendocrine tumor, but this architecture is fairly helpful. And so seeing this beginning of these sort of papillary structures, as well as seeing areas like this where you begin to get a little bit of hemorrhagic deterioration, maybe a few histiocytes coming in, that can be a nice marker as well. But these cells are, fairly uniform. They're round oval. Now, they do tend to have nuclear grooves, which is a nice marker and somewhat helpful because most neuroendocrine tumors do not have good nuclear grooves. Now, I can't show you them quite as well as I could if I had higher magnification because we only scan this at 20x. But here you can see a groove in that nucleus, and there are a few others. Here's one here, and a few others if you were to look around here. Here's one where the tumor is almost completely degenerate. And we look at this and we might even wonder if this is really what it is. You see all these cholesterol clefts. Here's an area of extensive hemorrhagic necrosis. And it's really almost just the ghost-like architecture here of these hyaline cores with a bit of cellularity around them that sort of suggests that this was a solid pseudopapillary tumor. Because I'm not sure that what's left here in terms of the viable cells are really the cells of the solid pseudopapillary tumor. These may be just histiocytes. Now, if they were beta-catenin positive, I'd believe it and say, okay, great, a solid pseudopapillary tumor. But this is not the usual architecture of solid pseudopapillary tumor. It's more like an infiltrated histiocytic response. And so in large respect, this tumor is one that tends to degenerate fairly readily in these circumstances. But when you see a lot of cholesterol clefts in this situation, you'd think, well, maybe granulomatous pancreatitis or something of that sort. But you do need to remember that solid pseudopapillary tumor can give you this appearance. Now, here's an area where we have a very remarkable kind of clear cell change without the kind of deterioration in between these fibrovascular cores. And I don't know the staining results on this, but looking at the cells, I could believe that these were either neuroendocrine or possibly solid pseudopapillary tumor cells with just this very lipidized or vacuolated appearance. So this is an area where I would be interested to know what our immunophenotype would show us and if that would give us the clue to a viable area of residual solid pseudopapillary tumor. Here's our remaining pancreas over here. Okay, so let's see if we have one more. I think I may have some immunostains that go along with this. So here's another example of solid pseudopapillary tumor. Not so much that, but you see the cystic change is present here. And over here, it looks really quite neuroendocrine-like because it's got sort of this nested appearance and so forth. But here you see these very hyalinized areas here. And so it's looking very much like a neuroendocrine tumor. And so this is a frequent differential that we encounter. And that's where the value of the beta-catenin comes in. Now here we have more classical architecture with the pseudopapillae and the dissolved hemorrhagic areas in between these papillae. So the last tumor I want to cover in any detail here is acinar cell carcinoma. This is usually more frequent in males, but does occur in females, and it's usually older adults. More ahead of the pancreas than the tail. And this is a tumor that can be Lynch syndrome associated. So while ductal carcinomas can be Lynch syndrome associated, this is also another that can be. And this is a tumor because it's less frequent. We don't think of it as often, but it doesn't behave in quite the same way. But because it's occurring in the same age group and demographic, we can occasionally miss this tumor on biopsy or misclassify it if we're not remembering to think about this possibility. Because this can look a little bit like neuroendocrine tumors. It can look a fair bit like ductal carcinomas. And that's true especially on cytology. And so thinking about it and remembering to consider it is important. The key stain here usually is trypsin. And so this is not a widely available stain. We usually have to send it out. But the overlap here is that this can also occasionally be beta-catenin positive. And so you could be thinking solid pseudopapillary tumor, except that the age group won't match. Now, if you are able to do molecular genetics, In contrast to the usual ductal carcinomas, you will not find KRAS or SMAD4 mutations, which are very common in ductal pancreatic carcinoma. These instead tend to have BRAF or RAF1 or RET rearrangements or all three. And so there's a different molecular biology going on in this tumor. And that, of course, explains different responsiveness in many respects. So here's an example. As you can see, we have a little bit of residual pancreatic tissue here that looks normal, but then we have these areas here where there is a degree of lobularity here, but it is altered to a significant degree and is composed of, as you'd expect, acinar type of epithelium, but it's not organized in the way that a normal acinus is, even though it has this sort of vaguely lobular appearance. And that can be deceptive at times in this circumstance. But the associated, changes here in the lobules of the variability and then the extension into surrounding tissues. Now, if we needed further evidence of its invasiveness, we might need to look a little bit more closely at other areas. Maybe a little bit in there. The contrast here with the normal acinar epithelial or parenchyma is quite helpful as well. So normal acinus and neoplastic acinus over here. And then we'll look down here at the bottom. And I think we can see here it's extending into the bile duct and the main pancreatic duct, causing some ulceration here as well. So a little bit of a subtle type of pattern that in its pseudolobular architecture can mimic just kind of degenerating acini. But this is just way too cellular here in the tissues to be residual acini. And then you have the control tissue. Now I've got another example here as well. This is a little bit more classical sheet-like pattern of growth and very abundant eosinophilic cells, very granular nature to the cytoplasm. I think most of us would look at these and say, oh, these look like acinar cells, but it's not in an acinar configuration, so it must be acinar carcinoma. Another example. And again, we see a little bit of packeting here and so forth, but distinctly different from the adjacent normal acini. Here, there's almost a signet ring type pattern because there's so much granularity to the cytoplasm in terms of its products, and it looks quite different from this. But when a lesion like this becomes invasive in a more diffuse pattern, now this is invasive, of course. Here you see some, lymphatic space invasion. But if it's in a more diffuse pattern, it can be quite insidious. Okay, well, I think we're just about at the end of the hour here. I had a couple of other lesions that I included in the slide deck, but I'll let you look at those. There's a giant cell carcinoma and a mixed neuroendocrine and adenocarcinoma as well. But if we have questions, I'd be happy to answer any questions that people might have or want to put forward. Well, you're not a very talkative group. But thank you for joining it in the session. And if you do have questions, or if you look at the slides later on, please feel free to get in touch with me. Of course, a lot of times now, rather than just cytology, we're seeing biopsies of these lesions that are performed via endoscopy and obtaining core samples. And those can be much more challenging to interpret. And perhaps we can do a special session on that at some point when we've collected enough examples. I do see them quite regularly now in our practice, and so I'll try to accumulate some of those. Well, I guess with that, I'll wish you all a good day, a good weekend, and thank you for listening in, and welcome your questions whenever they come along.
Thank you so much, Dr. Hassan. And you too have a great time.
Okay.
Thank you.